the indications for testis sparing surgery when you are dealing with testicular cancers?
So the indications for testis sparing surgery will include a solitary testicle for any reason, such as someone who's had previous contralateral orchidectomy and presenting with tumor in the residual testis. So this would be the main indication for testis preserving surgery. If also there's suspicion that ultrasound findings are not clearly confirmatory, then testis preserving surgery could also be considered.
Okay. Take me through insertion of testicular prosthesis. You have finished your orchiectomy.
Okay, so my considerations and my approach to testicular prosthesis insertion is that this is a prosthesis insertion with a potential risk of infection. So I will limit the number of patients in theater, ensure that this is done in a laminar flow theater, and that everyone has appropriate PPE and masks on. I will use a non-touch technique and impregnate the prosthesis in betadine or gentamicin antibiotics. To select the size of a prosthesis, I will roughly measure the contralateral testis to gauge an appropriate size. Patients should have had antibiotic prophylaxis as part of intraoperative induction. Following on from that, I will introduce the prosthesis and anchor the prosthesis to the dependent or fundus of the scrotum with a non-absorbable suture. I will then close the bladder neck to avoid proximal migration of the prosthesis.
Okay, what do the prostheses are made of?
So they're made of silicone.
Okay, and how are you going to fix the prosthesis in the main fundus of the scrotum?
So there is an anchor on the prosthesis, which I will backfeed my suture, non-absorbable suture, maybe number 4 proline or number 3 proline, and anchor that to the fundus of the scrotum and tie that down, and then reduce the prosthesis down to the scrotum and close the scrotum neck.
Okay, what are all the indications for contralateral testis biopsy?
According to the EAU guidelines, the indications for contralateral testis biopsy will be a patient less than 40 years with a small testicular volume less than 12 mils. This should also be considered in patient with poor sperm parameters, as well as patient with a history of undescended testis on the contralateral side.
So what are you planning to find in the opposite testis?
The main thing of concern in the contralateral testis is intratubular germ cell neoplasia, which coexists in about 5% of testicular cancers. However, with the risk factors, this can go up to 35%, hence the need to biopsy.
Okay, how will you histologically classify testicular cancers?
So according to the WHO classification, testicular cancers can be classified as seminomas, spermatocytic seminomas, and non-seminomatous germ cell tumors, which would include teratoma, embryonal cancer with teratoma, pure embryonal cancer, yolk sac tumor, choriocarcinoma, and then the non-germ cell tumors such as Leydig cell tumor, Sertoli cell tumor, and lymphomas.
Okay. Could you explain the TNM classification for testicular cancers?
So the TNM classification for testicular cancer is as follows. TX, tumor cannot be assessed. TIS, intratubular germ cell neoplasia. T1 is tumor involving the testis with no lymphovascular invasion and no invasion of the tunica vaginalis. T2 is lymphovascular invasion or tunica vaginalis invasion. T3 is tumor involving the spermatic cord, and T4 is invasion of the scrotum. NX cannot be assessed. N0 no lymph node mets. N1 is single or multiple lymph nodes less than or up to 2 centimeters. N2 single or multiple lymph nodes 2 to 5 centimeters, and M3 more than 5 centimeters. MX mets cannot be assessed. M0 no mets. M1 A is metastasis to the chest lymph to the mediastinal lymph nodes or lung metastasis, and M1B is non-pulmonary visceral mets.
What about the S staging?
There is the S classification as well, taking into consideration the tumor markers. So S1 is LDH less than 1.5, upper limit of normal, beta HCG less than 5,000, and AFP less than 1,000. S2 is 1.5 to 10 times for LDH, 5,000 to 50,000 for HCG, and 1 to 10,000 for AFP. And S3 is levels above S2.
Okay. What is the predictors for relapse in seminoma and non-seminoma?
So the histological predictors for relapse in seminoma include tumor size more than 4 centimeter and invasion of the Rete testis. For non-seminomas, this include lymphovascular invasion, presence of embryonal components more than 50%, and proliferation more than 70%.
Okay. If there is a biopsy showing germ cell neoplasia in situ, what is your approach?
So it's important to explain to the patient that with the presence of ITG-CM, there is a 50% chance of progression to invasive cancer in 5 years. So I will explain this to the patient. However, patient can be, the management options would include surveillance or radiotherapy to the contralateral testis.
Will the testis being solitary testis or presence of contralateral normal testis affect your decision making?
So it would affect my decision making in that if it's solitary testis and the patient, for instance, wants to have a family, they can be encouraged to defer any treatments and go have a family with close supervision and self-examination, and then to consider treatment after that. So this will affect my decision making. Yes.
Okay. If it is opposite is normal, what's your plan?
If the opposite is normal and it's just germ cell neoplasia in the solitary testis, then the option can be expanded to include an orchidectomy on that side.
Okay. Let us assume that your patient has got histology of seminoma 3 centimeters and histology shows no Rete testis invasion. What is your treatment plan?
So this patient, given these histological features, has about 6 to 12% risk of developing retroperitoneal mets down the line, compared to 32% of patients who have the risk factors present. So I will explain to the patient the management options, which would include surveillance or a single shot of carboplatin.
Okay. How will you dose the carboplatin?
So carboplatin is calculated using area under the curve to come up to 7 milligrams per mil.
What do you mean by the area under the curve?
So it's calculated. I'm not exactly sure of the details, but it is a graph which is extrapolated to work out the appropriate dosing, which will give the area under the curve of 7 milligrams of body weight.
Okay, good. We have finished 10 minutes. I'll give the feedback and then we'll discuss further. So area under the curve is kind of plotting of blood concentration in the y-axis, and in the x-axis there will be time. So all we want is a particular concentration of the carboplatin. We are trying to maintain the carboplatin to extend up to that particular value of 7 area under the curve. It depends upon the individual patient, because if a patient's renal excretion is excellent, you may have to increase the dose. If the patient's got low EGFR, with low dose they will achieve better area under the curve. And it is a computer generated curve, and the dose, actual dose milligrams, will depends upon the patient's excretory status, age, body mass index, etc.
Thank you.
Taking you back through the starting of this scenario, testis preserving surgery, you can think in if there is a suspicion of the benign tumors, and also for synchronous and metachronous bilateral tumors, not only the solitary tumors. And if there is a need, you may have to do a kind of invagination of the scrotal skin into the inguinal incision, so that you can fix the testicular processes comfortably, and then take the processes into that and then close the bladder neck. For WHO classification in N2, the size of the node is not only between 2 centimeter to 5 centimeter, also the number of lymph nodes less than 5, that is also included. If you look quite diligently, the number of lymph nodes should also less than 5, not only the size. And for germ cell neoplasia in situ, for solitary testes, radiotherapy, the dose is 20 gray in the fraction of 2 grays per fraction. So these are a little bit here and there, so that the answers look more better, and then you can try to get the maximum out of the testicular cancer table, because this table is the one where it's very easy to score complete mark. There is no deviations, there is no need to bring any big references or articles. If at all, if you bring EAU 2021 guidelines here and there, that's more than enough. Isn't it?
Thanks.